Voice podcast with me, Natalie, and my wonderful co-host, Issy.
We hope you're having a lovely week. We're recording this episode in October, but I imagine by the time we've released the episode, you might even be feeling a little bit festive.
I know for a fact I'll be in full Christmas spirit. As soon as Halloween's done and we're in November, I'm ready.
Anyway, back to why we're actually here. We have a really interesting episode lined up for you guys today. We'll be joined by Laura Harbert, the clinical lead for speech and language therapy in critical care at St Thomas's Hospital.
We'll be learning from Laura about what the role of an SLT in critical care actually entails, what it was like during COVID-19, and Laura will also be helping us get to grips with all the tricky terminology.
Without further ado, let's get started.
Hi Laura, it's so lovely to have you on the Giving Voice podcast today.
Thank you for having me.
It's so great to have you here with us.
Oh, I feel very honoured to be asked.
So to begin with, we'd love to hear a little bit more about you and how you ended up in your clinical lead role that you have now.
Thank you. So I always knew I wanted to be hospital-based, even before I knew which profession I wanted to go into. And then when I discovered speech and language therapy, I was really drawn to working with adults. I just felt like I'd feel a bit more comfortable interacting with adult patients. And that was really emphasised throughout my placement, sort of feeling a bit more comfortable. And I did have a really great variety of placements. I was really lucky. I studied like you at UCL and I did the undergraduate, so I had plenty of time to sort of get a feel for different kinds of client groups.
Yeah.
And I was community-based, neuro rehab and acute. And so I just really felt like I liked the fast-paced adult environment and also the opportunity to sort of get immediate opportunity to do MDT working. I really enjoyed that factor of the fast-pacedness and getting immediate answers.
Yeah.
And I worked as a band 6 for a really long time, about 6-7 years. But on reflection, I think that was a really good opportunity to try out different caseloads. So and that led to my band 7 critical care role, and then eventually the opportunity for the lead role, so band 8. So yeah, really enjoying it. And I'm very lucky that in my clinical lead role, I'm still very much clinical, as much as I can be. So
oh, that's great.
Yeah. I always felt like it wasn't somewhere where I wanted to direct my career because I wanted to be clinical, but actually I'm lucky still to have that opportunity.
Yeah.
And I think it's important to still be on the shop floor, as they say, having exposure to those patients. Yeah.
So how much of your time would you say is clinical and working face-to-face with patients, and how much is working more higher up?
I think probably about 50-50 probably.
Okay, wow.
And even if it's not direct patient facing, it's patient associated. So working to support colleagues with video fluoroscopy clinics, things like that as well. Yeah.
Oh, that's so great.
Yeah, that's so nice to have a balance of the two, isn't it? I think.
In terms of the leadership part of the role, I'm enjoying doing things like being involved with departmental policies and upskilling the team and going through competencies, and that's why it's such a nice mix. Getting to work with lots of different people at different levels and also across different trusts.
And it's likely that many of our listeners may not have realised that an SLT, their role can actually extend to working in critical care. Personally, I remember before starting the course, I thought that working with adults would mainly involve helping stroke patients. So we were wondering whether you could tell us a bit about the critical care unit you work in and what a typical working week looks like for you. Yeah,
that's definitely the question you get asked if you speak to somebody who doesn't know about speech therapy. People will at least be familiar with strokes, and so that is definitely the answer I get when I say, and sometimes I just nod and say yes.
It's easier.
You sometimes lose people's interest when you actually get into the nitty-gritty, or they don't really want to hear about some of the, it feels a bit confronting to talk about our role, particularly during COVID and that sort of level of understanding. So, but Guy's in St Thomas's is a gastroenterology and cardiac centre, tertiary centre. So we have lots of patients that come through for planned elective and emergency admissions associated with those surgeries. And also, of course, just respiratory failure patients. So It's a very mixed bag in terms of our critical care caseload, which is another reason why I love it. No 2 days are the same.
Yeah.
Patients are so present in such different ways. But yeah, so a typical week can be very atypical, but we would always gather together with the rest of the team, the wider team across all of the acute wards, and have a Monday morning caseload meeting so that we can discuss any tricky cases, give support to each other, share interesting learning points, and sort of organise our video fluoroscopy and fee service. So fees being the assessment of swallow via a nasendoscopy. And that way we sort of have an overview of each other's week and what the pressures are on each other, see how we can support one another as well.
Yeah.
We have a lot of training and teaching that we do, and some of that's internal. So we'll have a weekly in-service training slot where we can present on cases or journal articles, or welcome external speakers, feedback on conferences, things like that.
Oh, that's so interesting.
Yeah, which is a lovely opportunity.
So would you say then the dysphagia work is mainly what you're doing on the role, or...?
A real mixed bag. So lots of communication, oromotor, swallow assessments, looking at voice, tracheostomy, weaning. So yeah, it's vast.
So I think some of our listeners may not know what a tracheostomy is. Could you tell us a bit about what a tracheostomy is, when it's used, and what tracheostomy weaning is?
Yes, of course. So a tracheostomy is essentially an artificial airway, and it's inserted below the level of the vocal cords. So in the early stages, the patient won't have any voice, and their swallow may well also be impacted. So there's no airflow going from the lower airway up through the vocal cords to vibrate them, and then through the mouth to give voice. So there are 3 reasons why a patient may need a tracheostomy. The first would be for more efficient ventilation. So by connecting the ventilator to the tracheostomy, you're not having to utilise the upper sort of an area referred to as dead space in that case. So it's closer to the lungs. Another reason might be to bypass an obstruction. So, for example, if a patient had a head and neck cancer or an obstruction to the upper airway. And the third reason might be because the patient might be needing deep suctioning. And it may be a combination of those reasons. And you could have an emergency tracheostomy, or it may be planned as part of their surgery, or in order to facilitate better ventilatory support in that case. So the reasons why SLT would be involved, so weaning means working towards getting the tracheostomy out.
Okay.
So it would be a very sort of stepwise process, working with the rest of the team, and as and when the patient is ready, you may wait until the patient's off the ventilator to start their wean, depending on the patient, or they may still be supported with mechanical ventilation in addition to starting that wean. So we would first get the cuff down. So there's a balloon or a cuff that sits around the outer circumference of the tracheostomy, and between the outer circumference and the trachea itself.
Okay.
It might be sort of useful for listeners to have a look at a picture of how that looks in situ.
Oh, that's a good idea.
Because it's quite an abstract thing to get your head around.
Yeah.
And that cuff means that at that point there's no airflow going up through the upper airway. So by getting the cuff down, it gives resensitization to that area and allows the patient to be able to smell and taste again. So it's important that we're warning patients that they're going to get those senses back.
Yeah.
And also hopefully elicit a cough response, but whilst they're getting used to that sensation.
Yeah.
And then we'd want to check if there is sufficient airflow around between the trachea and the tracheostomy, so that we know if we can then progress to using something called a speaking valve, or our preference is really to call it a one-way valve. And that's because we don't want patients to only be using it if they are speaking.
Right, yes.
So as part of also working towards getting their tracheostomy out, even if they're not communicating much verbally, for whatever reason that they're in a hospital. And so by having that one-way valve in place, it means that the patient can still breathe in through their mouth and nose, and also the tracheostomy.
Yeah.
But because we vocalise on the exhalation, the end of the speaking valve has flaps of plastic in there. And on the exhalation, they will shut off closed, and the airflow will therefore be sort of forced up through the vocal cords.
Okay.
Therefore achieving some voice.
Yeah. Oh, that makes sense.
And hopefully better swallow sensation as well, improved swallow. And then once they're comfortable with that resensitization and they're managing their own secretions, we'd then look towards doing a swallow assessment after that. But it's very patient specific, and working with the rest of the team to make sure that the timing's right and it fits around their larger parts of their rehab as well.
Yes, yeah.
So interesting. I never thought that your smell and your taste would be gone
No.
with the tracheostomy until you just mentioned. Yeah. Really, really interesting.
Yeah, I wouldn't either.
No.
There's some really amazing resources online that you can use to sort of get your head around what are the changes of airway and airflow when somebody's got a tracheostomy. And the NTSP website, which is the National Tracheostomy Safety Project, has lots of really great learning resources and images and videos of what it's like for a patient to undergo these kinds of procedures and just be in the critical care environment and get used to those changes and how their communication might change and swallowing. Yeah.
Oh, that's so interesting.
Definitely. We'll have to check that out.
So is a tracheostomy, is that something that's reversible, or is it?
Yes, absolutely, yeah. So the aim is for it typically to be short-term.
Is it uncomfortable for the patient at all?
That's a really interesting question, because I often think that for patients, and I have asked patients, but they tend to say no, that they're comfortable. You know, I'll ask them as part of a routine, have you got any pain? And sometimes I have specifically asked about the tracheostomy, and they might refer to some pain that's around that site, but they don't typically mean the stoma site. So the stoma is the name of the hole that's created for the tracheostomy to be inserted through, or the hole that's then left after it's taken out, but it heals very quickly. They usually mean that they've got some dryness inside their throat. It's not actually the placement of the tracheostomy.
I see.
But yeah, you would think it would be incredibly painful.
Yeah, visually it looks like it should be painful, doesn't it?
Yeah.
From an outsider's perspective.
Yeah, definitely.
The other thing is that obviously so many of our patients in critical care have so many things going on with their medical situation as a whole that they're often on heavy painkillers, and so that will hopefully be masking any any potential source of pain. So that's worth bearing in mind as well.
The other term that I hear a lot is laryngectomy, and I wonder if you could just briefly explain the difference between a tracheostomy and a laryngectomy.
A laryngectomy is where the whole larynx is removed. So that will be typically with patients who've had head and neck cancer, and that may come after other treatments, or it might be the initial main treatment, because if it's that severe, and it involves removing everything that's there, so vocal cords and all of the cartilage that's surrounding it. So that's a major surgery that is obviously irreversible. There's a lot of education needed before the surgery, counselling to make sure that the patients do understand that they will never use their natural voice again. And that there are some voicing methods that they might be able to explore after the surgery. But it essentially means that they should therefore be safe to eat and drink, because the trachea is moved so that there is an external hole or stoma in the front of the neck. And so the esophagus and the trachea are completely different tracts.
I see. That makes sense. Thank you. So you also mentioned earlier that a patient you might be seeing someone with communication difficulties, someone with swallowing, and then obviously there's tracheostomy weaning. So would you say that you typically see someone just for one of the areas, or do they often overlap?
Yes, there's a huge overlap. Sometimes it might just be for one part of their care, might be the priority for them at that moment, but because of being the experts in voicing and communication strategies and looking at swallowing and the nerves and muscle groups being the same groups, that's why we've become so much more instrumental in critical care in terms of tracheostomy weaning. So first of all, we'll be seeing a patient in the early stages, either if they're awake and intubated for communication support, or if they've got a tracheostomy and the cuff is stood up. So we always want to make sure that they're able to access a communication method that feels as normal as possible to them and as close to voicing and as low impact. If voice isn't a potential option, then we want to look at sort of low fatiguing, easy access options.
Right.
So looking at AAC or alternative augmentative communication, total communication methods. So writing thumbs up, thumbs down. What are they going to find the least limiting? So making sure that they're able to communicate what's on their mind, what's worrying them is so important. So yeah.
Yeah, and so I can imagine a lot of what you do, you work in a multidisciplinary team, and you mentioned that a little bit earlier. What members of the MDT do you sort of work with on a typical day or over a typical week?
So we work really closely with physio for tracheostomy weaning. So we'd always do the first session or multiple sessions with physios, and also obviously the nurse, because they're with the patient all the time. So the major difference with critical care is that it's one-to-one nursing if they're a patient with higher care needs, or if they're needing multi-organ support. If they've just got one organ that's needing supporting, they might be in a high dependency unit instead, and in which case you'd have one nurse to two patients. And then if we do start somebody on oral intake, then we'd liaise with dietitians and let them know so that they can adjust the enteral feeding that the patient's having. So any feeding via a nasogastric tube, for example, and then we need to make sure we're telling the food service assistants so that they know which food to deliver. So we also work closely with pharmacy for advice regarding drying agents and medical teams. So if a patient's not managing their saliva, it may be that having a short-term pharmaceutical method to dry up their secretions might be useful.
I see.
So we produce 1.5 litres to 2 litres of saliva every day, and if we're not swallowing that, then it's likely being aspirated. We'll be also sort of looking at what the trends are with how a patient's chest safety is as we progress with a tracheostomy wean. And also with swallow assessments. So if somebody's chest isn't looking so healthy, if they're needing more suctioning, then that might be an indicator that we're pushing too hard with the wean or with their swallowing recommendations.
That's so interesting. It's so, actually to hear how medical an SLT's role can be. And I think, like Natalie, you mentioned earlier that before you came to the course, you didn't know much about tracheostomies and critical care. And it's so incredible what actually the day of a life of an SLT can look so different in a hospital compared to, in a school.
Absolutely.
Yeah, so interesting. And you mentioned that I think it's nurses who have they tend to work with a patient over multiple shifts if they're one-to-one. Is that in the SLT team? Do you try and allocate different patients per SLT so that they have some continuation? Yeah,
absolutely. So we'll try to have some continuity so that there's not so many handovers, because that can also be a safety point. If you're handing over patients, then you might be missing some of the salient points. So, and also helping to sort of build rapport with the patient, and it's just more time efficient if you've got one speech therapist who's seeing the same patient. But then it's also quite nice to not be too protective over who you're seeing, because if you're seeing a presentation that no one else has seen before, an unusual diagnoses, and there's you've got to do a bit of problem solving around, and they might need multiple instrumental assessments, and that would always involve more than one of us anyway. So it's quite nice to have a bit of a team approach and it not just be a discussion until you've actually set eyes on that patient and had some input. Obviously patients can be quite heavy emotionally. And so sometimes it may be that a nurse is asked not to be with a patient for multiple shifts. If you've got a very delirious patient, so confused, and they're thrashing out, those kinds of patients can be really difficult to manage. It's nice as well if that load is shared. And as well, if obviously being in central London, we see a lot of patients where English isn't their first language. So they will try to cohort nursing staff who might speak that language.
Oh, that's really good.
Being that patient. So rather than having to rely on family members or language line and translators to help us with our sessions, it's obviously so important that we're giving those patients as well equal access to be able to communicate their needs. Yeah.
I remember I was lucky enough to join you at St Thomas's during the summer for my placement, and I remember there being a Spanish-speaking nurse, and it was, you could just see how important it was to have someone there that spoke the same language, and how valuable that can be on a medical team, really, because they can communicate things that perhaps a family member might find more difficult, and really valuable.
Yeah, and so important for the patients. It's already such an isolating experience, and patients feel, what we know from what patients report back is that they feel so vulnerable.
And I remember you mentioned earlier in the podcast as well about your role during COVID. I remember we discussed this during the summer, and I found it really interesting because you were really right at the forefront. I wondered, would you be able to share a bit about that as well?
Yeah, it's obviously a really sort of strange and traumatic time for so many people for multitude of reasons, but it was a time where we learnt a huge amount, and it sort of brought people together as well. So and learning as we went, sort of not really knowing what our role would look like. So it was sort of fast became apparent that actually we would need to upskill and look at our skill mix across the team, and making sure that the rest of the team on the acute wards was sort of happy with managing post-extubation dysphonia, so voice problems and dysphagia, just as a result of having that breathing tube, the initial endotracheal tube in for a prolonged period of time, and flagging that as a risk factor for a potential swallow problem. And that was a real big learning point as well for us, because more patients were proned, which means literally turning the patient upside down.
Oh my goodness.
So that they're lying on their front, and that facilitates better ventilation of the lungs.
Right.
So that the pressure isn't always on the back of the lungs.
Yeah.
And that required sort of proning teams. So people were sort of surged from their normal departments that weren't so active, like dentists were coming to do enhanced mouth care, but also working as part of proning teams. And that would require a team of sort of 8 people to come and turn the patient. But one of the implications of that was when the intubation tube is turned in the patient's throat, and then if it's in position and they're turned as careful as you might be, because obviously that's why it takes so many people to be careful of all of these lines, that they're not going to cause any damage, but that slight turning of the tube that's going between the vocal cords, which are very delicate, that then had an impact on how many patients we were seeing with dysphonias and dysphagias.
Wow.
So those kind of things that you would never have thought about, because I hadn't really, proning always existed, but I hadn't particularly heard of it. It definitely wasn't done as much as it was during COVID. Also, from sort of a service point of view, we have a 5-day service where I work, but we raise that to a 7-day service. So learning about how to make sure that handovers were seamless and picking up patients, but then making sure they had a safe plan and you had somebody to hand over to.
Must have been a really tough time.
Yeah, very, very tough. So interesting. No, thank you.
So I was wondering if you could tell us what your favourite moment has been from your time as a speech and language therapist in critical care.
For sure, I would say every session where you have been able to facilitate a patient being able to use their voice. So that's always kind of a moment where I think this is why I do what I do. It's sort of at the core of everything about the person. Voice is so particular to a person, and being able to hear them saying to their loved ones, "I love you," for the first time. Sometimes it's quite funny, precious. And actually it's the family member who wants them to say that, and actually that's not really coming through, and there's a lot of prompting for.
That's so funny.
But that's what they want to hear, which I can completely understand. I think I would be in exactly the same position. So facilitating voice is communication of any kind. I mean, if you're the first person to go along with a whiteboard or an eye gaze chart and establish a means of somebody being able to make their needs known, is obviously so important. But I think there's just something so much more powerful about them being able to use their voice.
Yes, that definitely sounds like it would be probably one of my favourite moments if I worked in critical care.
So rewarding to actually get a voice back is just fundamental, isn't it?
Yeah, absolutely.
And critical care must be quite a stressful and upsetting environment at times, as we've sort of heard throughout the podcast. We just wondered, on a lighter note, how do you like to switch off to help manage this?
Well, to start with, I suppose if it is stressful and upsetting, it's really important to seek the support from your colleagues, and to reach out to your colleagues as well to see how they are. So we try to use sort of a going home checklist, what was upsetting about your day or part of your day, sort of think about it, but then just try and put it to bed, because whatever was going on, it's in the context of this really stressful, upsetting environment, and so much of that is out of our control. And then thinking, okay, well, how else was my day? What went well? And reflecting on that as well. And then just sort of walking out the door and relaxing, recharging.
Yes.
And check. And then following up, if there's something that's still niggling, always seek sort of support from your supervisor and your colleagues. Yeah, I would say. But for me personally, when I walk out of work, it's nice just to have some fresh air. But then when I get home, I have 2 sons, so it's onto like a bath time, bedtime reading routine, and that's a great distraction. They were a fantastic distraction through COVID as well.
Yeah, I can imagine.
Keep you busy.
So, exactly. I sort of didn't have the headspace at the time to think about work when I wasn't in work. But otherwise, I love exercising, being outside. Quite like sewing.
Oh, lovely.
Doing
Very nice.
Creative things as well.
Yeah. Are you sewing anything at the moment?
Some curtains.
Very nice.
For our house. Yeah.
Very practical.
I'm very, very slow.
No, but that's so important to do the reflections at the end of the day, and I think that's a really healthy way to sort of wind down, really, at the end.
Yeah, I think there's many people who are listening who would probably love to work in an acquired setting, and I just wondered if you have any tips for getting a job in critical care.
I would say most critical care based jobs would be band 6 and above, because of the competencies and sort of the patients that you're seeing, so with tracheostomy skills, etc. But different units might work differently, and hopefully most settings will be fairly inclusive and helping you to upskill at an early stage if it's sort of appropriate for your caseload, and every department works in a different way. So exposing yourself to those patients through listening to case discussions, doing a bit of extra reading around the topic, and becoming familiar and confident with understanding what the patient trajectory is like. So thinking sort of backwards and requesting joint sessions, I suppose, or sharing information with each other. My first job was actually advertised as a band 6 role. And so I asked if they would consider employing me as a band 5.
Oh, wow.
If the interview went well. And maybe they saw it as a good money-saving option. But luckily for me, I was offered the job. And so that hospital had a much smaller critical care.
Right.
And although I didn't know it was where I wanted to specialise, it was nice to sort of hear about the cases that my supervisor was seeing and trying to learn from those. Yeah.
So you applied for a band 6 job. That was as your newly qualified position?
Yes.
And they gave it to you then as a band 5?
Yes.
That's really good to know that
actually
if we maybe see a job that is as a band 6 that we're really interested in, to sort of not just completely ignore it, to maybe reach out, contact them.
I'd say that would be my top tip actually as well. Would be if there's a job that you're interested in applying for, even before you've done your application, phone them, ask them if they're willing to have you come and visit even. Because then you get a real feel for what the department is like and what the caseload might look like, and you might get extra idea that might make you feel a bit more prepared when you come in to interview about the specific patients sort of groups that you might be seeing. And it also just shows that you're really interested. And you can learn a bit more about what you'll be expected to do.
That's such a great tip. I'm definitely going to be remembering that.
Thank you so much, Laura. It's been so interesting, and I'm definitely convinced to work in critical care. I don't know about you, Izzy.
Well, definitely working in a hospital. Definitely.
No, thank you so much.
My pleasure.
Yeah, thank you so much.
Thank you for having me.
It's been so great. That's it from us. If you want to know more about Laura's line of work, check out her Twitter, where she shares loads of great resources. Her handle is @Laura Harbert SLT. But don't worry, we'll put it in the episode description too.
We'll also be adding a link to the National Tracheostomy Safety Project website, which Laura mentioned earlier, so you definitely won't be short for resources.
See you next time.
Bye!